session. So the title or the theme for this particular session is Integration of Family Planning Services into HIV Care Clinics, which will get results from a cluster randomized controlled trial in Nyanza, Kenya. This is a pre-formed panel. So the structure of this particular session will first of all include an overview, and then we'll have 4 papers presented which touch or are related to this particular intervention. So with me I have the panel here, and I'd like to introduce them. And the one who will give us the overview first is Professor Craig Cohen, Professor of Obstetrics and Gynae and Reproductive Sciences at the University of California and San Francisco. And he has worked in Kenya since 1994. So I would like to take this opportunity to request him to give us that overview, to introduce this panel in terms of the thematic areas. So you're welcome, Craig.
Thank you.
Is it working? Oh.
Thank you very much, Dr. Solomon, and good morning. I'm very proud to be here in front of you to introduce the cluster randomized controlled trial of HIV and family planning integration, which we conducted in Nyanza, Kenya. This is the background. The prevalence in Kenya is about 7.4% nationally. However, it's about double that, about 15.1% in Nyanza, the province where we conducted this investigation. And even some of the regions where we work, in Suba, about 1 in 3 reproductive age women are infected with HIV. In addition, we know from prior research or research conducted in Kenya as well as other countries in East Africa that there's a very high unmet need for contraception among women living with HIV. In fact, in Uganda, there was one study that demonstrated that 90% of women living with HIV desire contraception, either to delay future childbearing or not to have any future childbearing in the future. Prevention of unintended pregnancy has many implications. It is one of the cornerstones that you heard earlier this morning for the prevention of mother-to-child transmission. And also it has a side benefit or a direct benefit on maternal mortality and neonatal mortality, thus touching on MDG 4, 5, and 6. In regards to background, we decided to conduct this study because in looking at the literature and looking at reviews that have been done on this subject, there's really a lack of rigorous evidence to suggest that integration, and I'll define what I mean by that in just a moment, actually is efficacious or not. It actually has the intended effects on the outcomes that we wanted to measure. And this is true in the field in general, that most studies that are conducted are prospective or retrospective, but they've not utilized experimental design. There were 2 recent studies, cohort studies conducted, one in Nigeria, one in Kenya. And they actually both found that there was no association between integration of services with the use of more effective contraceptive use. This includes permanent hormonal methods as well as intrauterine methods or pregnancy incidence. They did see, however, an increase in condom use with integration in the Kenyan study. Therefore, the goal of this study was to assess whether integration of family planning services into the HIV clinic increased contraceptive prevalence among HIV-infected patients in Nyanza, Kenya, and also provide evidence on the effect of integrated services in order to guide policy and service implementation. So specifically here, one of the talks will touch on the cost effectiveness of this approach. As I mentioned, this is a randomized cluster-controlled trial. So for those of you who may not be very familiar with this methodology, most randomized trials randomize at the level of the individual. So an individual comes into a study, they're enrolled, they either get drug A or drug B or placebo and drug A. In this case, we randomize at the facility. As you can imagine, it wouldn't be very possible to randomize at the level of an individual. So, and And our major outcomes were to looking at more effective family planning methods, and also the secondary outcome being pregnancy rate. We randomized 18 public health facilities in 4 districts in Nyanza in a 2-to-1 ratio, meaning that 12 sites were randomly selected to be an integrated model, and 6 facilities were randomized to the current standard of care. This included district hospitals, health centers, and dispensaries. So I just want to define more effective family planning methods, because you're going to hear this over and over again in these presentations. These include tubal ligation and vasectomy, hormonal methods, oral contraceptive pills, injectable, predominantly Depo-Provera, and contraceptive implants, as well as intrauterine methods. In regards to the timeline, this study was conducted over approximately a 2-year period of time. In the initial 3 months, we collected baseline data where we interviewed providers and clients in regards to their contraceptive needs, their interest in integration, and we started to collect that baseline information also on contraceptive prevalence. In the second phase, we had designed working very closely with the Ministry of Health using their guidelines, also relying on other tools that were provided to WHO and other partners like HIV 360. We actually created the SOPs, if you will, on what integration would look like in these facilities. We started to then train those facilities, and the 12 facilities in the intervention arm, it took about a 7-month period to go through do that. During that period of time, we were collecting baseline information, which we used then to compare the post-intervention phase, which went on for an additional 12 months. These are 2 photos, actually, of the Gori District Hospital. One is of the HIV clinic, or they also know in Kenya as the PSC, and one is of the NCH family planning clinic. I'm going to use this diagram to quickly let you know what the intervention looked like. So at all sites, we did system strengthening. It's really important to understand what we're evaluating is truly the impact of integration, not system strengthening, because this is done at all sites, regardless of the control site or prevention site. This includes training, mentoring, supportive supervision, and commodity and security and community engagement. Also, we help the Ministry of Health staff to establish health talks. So while patients are waiting for HIV services in the morning, they would have peer educators, predominantly, who are usually men and women living with HIV, talk to them about contraception and about family planning. At the control sites, which is the standard, has been the standard in many countries, HIV parent treatment was provided in the HIV clinics. And then patients then were linked or referred to the NCH clinic that may have occurred on the same day, may have been on a different day. In some of the smaller facilities, it may have been the same providers, but it was a different room usually where those services were provided. This is the standard. This is called linkage care, although some institutions do think of this as integration. This is more of the supermarket model that we heard during other studies today. Now, at the intervention site, which we call integrated, everything was provided in the HIV clinic. Providers were trained to provide HIV parent treatment as well as family planning, including insertion of implants, including insertion of IUDs, one-stop shop. So this is the one-stop shop model. Thank you.
Thank you, Craig, for that overview. So now at least we know the context, which is basic intervention took place. And now we move on to the series of papers that will touch on how and the findings that came out of the various aspects of this intervention. And I will start with the first abstract, or the first paper, and that's going to be presented by Daniel Kosman. He's the Vice President for Research at the IV's Reproductive Health in Oakland, USA, with the Assistant Professor in Obstetrics and Gynecology at the University of California and San Francisco. So he's going to take us through the first paper, which is titled Effect of Integrating Family Planning Services into HIV care and treatment on contraceptive use and pregnancy among women in Nyanza, Kenya. And how we have structured this paper presentation is that each paper should take not more than 10 minutes. So I hope that's what you. So over to you, Daniel.
Great, thank you for that information. Good morning to all of you. So as Dr. Coyne mentioned, I'm going to be presenting the main results from the cluster randomized trial. As he said, the objectives of this study was to determine the effect of integration and the use of more effective contraception. And the secondary objectives that we looked at were the impact on condom use, on dual method use, and on pregnancy. So the data for this study came from electronic medical records of women who were aged 18 to 45 who attended one of the 18 public sector HIV clinics in the study that Dr. Coyne described. And we have abstracted data from these electronic medical records on demographics, contraceptive use, and pregnancy. And I should say that we relied on women's self-report for pregnancy, and we did not perform routine pregnancy tests as part of the study. For this analysis that I'm going to be presenting here, we compared contraceptive use between the baseline period, December 2001 to February 2002, before integration was begun, and compared that to the final 3 months of follow-up period, so after about a year of the integration intervention, between July 2001 and September 2011. For our primary outcome, we looked at family planning use dichotomously, meaning we lumped together all users of more effective family planning and compared them to women who used less effective methods, primarily condoms used alone, or no method. So for our analysis, we used, for both the primary outcome, the use of more effective contraception, as well as the secondary outcome, condom use, we used generalized estimating equations in order to detect differences between use of these methods before and after the intervention, while controlling for clustering within sites and adjusting to the baseline measurement. For the secondary outcome, incident pregnancy rates during the follow-up year, we just adjusted for clustering. This table shows some of the baseline characteristics of this sample that we were working with in Nyanza at these 18 sites. This again is just the data from women. And you can see that the median age is about 30 to 31. The vast majority of women in this population had primary school education or less, slightly lower levels of education at the integrated sites. And most women were married or had been widowed, and about half of women were on ARVs. So this slide shows the main results from the study. Since the unit of analysis for the cluster randomized trial is the clinic site, the denominator for the proportions that I'm presenting here are patient encounters. And the data represented here on the left, from the baseline, represents data from about 5,600 patient encounters at baseline from about 3,800 women. And then the two bars on the right represent about 12,500 visits during the final 3 months of follow-up from about 6,600 women. The light blue bars, the top, sorry, it doesn't show up very well. The thing that you can't see at the top is the proportion of visits where women reported use of no family planning method. The next bars below, the lighter blue, are women who reported using less effective family planning, namely condoms alone. And then the darkest bar at the bottom, including the hash lines, are women who were using more effective family planning, meaning, again, hormonal methods, intrauterine contraception, or sterilization. And so this includes, we're lumping together here, women who were dual method users, meaning they were using condoms as well as more effective methods, and that's the hash line. And then the dark blue line, the dark blue bar, is women who were using more effective contraception alone. And you can see here that the proportion of encounters where patients reported using more effective family planning increased from the baseline period to the final 3 months of the study, the period that we call the end line part of the study here. In fact, at baseline, more effective family planning use was slightly lower at the integrated site, 17% versus 21%. And you can also see here how the use of more effective family planning was somewhat higher at the integrated sites at the end compared to the non-integrated sites. So during the final 3 months of follow-up, at 37% of patient encounters at integrated sites, women reported use of more effective family planning compared to about 30% of patient encounters at control sites. You can also see how dual method use increased over time in both study arms, from about 10% at sites during the baseline period, so again, the hash bars, compared to about 20% at integrated sites and 18% at control sites. And here are the results of the GED analysis, where we controlled for both clustering within clinic sites and the baseline measurement. You can see the adjusted odds ratio presented here compare the integrated sites to non-integrated or control sites at the end of the study. And as you can see, women presenting to integrated sites during the final 3 months of this follow-up period had a 55% increased odds of using more effective family planning compared to women presenting at control sites. And this increase was statistically significant. At the same time, we observed no significant change in reported condom use, meaning condom use alone or condoms used together with another method, or, again, no significant change in dual method use either. Neither of those were significant. There may be a slight trend toward decreasing condom use. The odds ratio was 0.82. Again, this is not significant with the confidence interval crossing 1. Here's the breakdown. I'm not sure how this projects very well. Of the use of more effective family planning by method. And I just want to point out here, well, first of all, that the denominator here is actually women, it's not clinic visits. And note that the y-axis is up to 40% on the left. And on the left, the 2 bars on the left, you can see reported use of more effective family planning at baseline, comparing integrated to non-integrated sites. And then the 2 bars on the right is the use of more effective family planning at the end of the study. You can see oral contraceptives are shown in yellow, injectables are in red, implants are blue, might look kind of black there. There's a very thin green line for IUCD, and then sterilization is light blue. And here I just want to show you the percent increase over baseline for each method where there was an increase of more than 1%. So as you can see, we saw the biggest increase in the use of injectables, an 11% increase over baseline at integrated sites, and a 4% increase at control sites. We also saw a sizable increase in implant use, 6% increase in integrated sites, and a 4% increase at non-integrated sites. There was also some increase in sterilization use, and this was the same in both arms of the study, about 2%. Here we have the data on incident pregnancies during the study period. So we were able to date pregnancies that were identified during the study period using the reported last menstrual period or estimated date of delivery in order to identify only those pregnancies that were actually conceived during the final year of the study. And we report them here as incident pregnancies per 100 woman visits. And although the proportions of women who became pregnant during the study during that follow-up period appear quite different, you can see it was 1.4 per 100 women visits in integrated sites compared to 1.9 in the non-integrated sites. Actually, in the GED adjusted analysis, this odds ratio was not significant. And you can see the odds ratio was 0.95. It appears that the higher number of pregnancies that we observed in the control arm primarily were clustered at one site that had a fairly large sample size, and we're exploring this in future analysis. So in conclusion, it appears that integration of family planning services into HIV care treatment in this setting, in Nyanza, when we performed this study, had a significant increase in the use of more effective family planning methods, especially the use of Depo-Provera and implants. With a very small increase in IUCD use. That's really very different. I think more work needs to be done. We observed no significant change in condom use or dual method use. And I think this really highlights the importance of messaging and counseling around dual method use in the context of promoting more effective family planning. We did not observe a change in incident pregnancy during the study, although I should point out that it was really 1 year follow-up. It's a fairly short duration to actually expect to see that kind of change. I think also this really highlights the utility of the cluster randomized trial design in order to identify the specific effectiveness of integration, as Dr. Cohen mentioned. We observed a significant increase in the use of more effective family planning at the control sites as well, because of the system strengthening that we did at all of the sites, but because of the design, we're able to particularly identify the contribution of integration to that increase in more effective use. In terms of the policy implications, as the first randomized trial to demonstrate improved uptake of more effective family planning as a result of integration, our findings really provide solid evidence supporting the policies that promote the integration of family planning into HIV care treatment in order to better meet the needs of HIV-infected individuals. We also demonstrated that it's really quite feasible to provide all family planning methods in the context of an HIV clinic. Well, certainly additional research and programmatic work is needed to identify strategies to improve the uptake of intrauterine contraception in this setting. In our study also highlights the importance of how counseling on dual method use is really a critical component of integration. And our findings are reassuring that the promotion of more effective family planning is possible without reducing confidence.
Yes, thank you, Dan, for that really interesting findings research. And keeping time, just give another few more minutes to use it. I guess we'll use it for our discussion when it comes to discussion time. So now we move on to the next paper presented by Mariciana Onono, Dr. Mariciana Onono. She is a research scientist, works in Cambridge, Kenya, and she also is the Nyanza research coordinator. She will present the aspect of this panel which is titled Changing Familiarity with and Attitudes Towards Family Planning Among HIV-Infected Men and Women after integrating family planning services into HIV care and treatment in Nyanza, Kenya. So over to you, Ms. Jan.
My presentation, as I said, will be on the I'll be presenting on the impact of integrating family planning services into HIV care treatment on familiarity with and attitudes towards family planning methods. And just as a brief background, we know that there are very many reasons for non-use of contraceptives. If you look at the demographic health surveys, they look at reasons why married women aged between the age of 15 and 49 would choose not to use contraceptives. They are basically classified into 4 reasons. One being opposition to use, either because the woman doesn't want to use the method, or there's opposition either from their partner or from other people, or even religious prohibitions. The second reason is a lack of knowledge, either a lack of knowledge because they do not know about the method, or they do not know where to get that method from. The third reason is fertility-related reasons. There are women who actually think that they are, subject and they cannot conceive. And then there's the all too obvious reason of maybe they're not having sex, or they're not having sex as frequently. And then the third reason, the fourth reason, which most people highlight, is method-related reasons. And in here we have the side effects of using family planning, the fear of the side effects, issues around access to the family planning, access being distant, as well as the cost issues. Additionally, based on some of the studies that we had done, we were concerned about this issue of negative male partner reactions. And so we wanted to also evaluate to sort of find out whether structural intervention of family planning and HIV integration impacts barriers related to partner opposition to and lack of knowledge of family planning. And so our main objective was to assess the impact of integrated family planning and HIV services on familiarity with more effective family planning methods and male attitudes towards women using family planning. And we did this looking at before and after the integration, and then we also compared between the integrated and the non-integrated sites. So in terms of methods, prior to the intervention, staff received training and education to strengthen family planning services at all sites. We basically had this 4-prong approach in which we did patient education using care educators, community and clinical health assistants, And then we trained the providers to be able to provide this method as well as be able to counsel on family planning. We also had provided logistical support, and in addition, we strengthened the monitoring and evaluation system across all sites. And then it's within this context that we were able to do a cross-sectional survey before we did the implementation and after the implementation. So for both the pre and the post, we had about 500 men and women for both the pre and the post. We then created a familiarity score. Within the questionnaire, there were questions asking them whether they had heard of a particular method. And if they had not heard of a particular method, we then prompted them to find out if, in a different way, So if somebody said they've never heard about pills, we'd also ask them whether, they've heard about, this tablet that women can take and, prevent pregnancy, or this small operation that women can undergo to, prevent pregnancy permanently. And then based on the responses that they gave us, we created this score ranging from 0 to 6, 0 if you didn't know any, and then 6 if you knew any of these methods that are listed here. We examined male attitudes towards family planning, and men were asked if they agreed or disagreed with the following statements. One, that contraception is women's business, and a man should not have to worry about it. And then whether women who use contraception really come from this field. These are very common feelings where we work. We then, for analysis, we did a multivariable analysis, which controlled for clustering within the sites. And then, as I said, we looked at differences in the baseline measurements and also between the integrated and the non-integrated sites. So in terms of the findings, you can see that most of our participants were 26 years and older. The majority had primary education or less. And the majority were either married or living with a partner. And I think interesting is that men were more likely to report that they were married than the women. We also asked about disclosure to partner status. Over 2/3 had actually disclosed their HIV status to their partner. Again, men reported to have disclosed their status more often than women did. Most of the participants reported that they had good health status, though we can see that the report of good health status was more in the integrated sites as opposed to the non-integrated sites. Most people had more than one living child, and approximately 75% of the participants, both male and female, desired either cease childbearing or delayed by 2 years. In terms of current use of family planning, regardless of the fact that 75% wanted to delay childbearing or cease childbearing completely, we can see that roughly between only 40 to 50% of the participants were actually using a more effective method. And so we can actually see that gap. And injectables top the list of the more effective methods that were being used. So this slide shows the results for the mean familiarity score. The score is ranging from 0 to 6. We converted it into 100%. And we can see that there was a change in score from baseline to endline at all sites. With a mean change of 4.47%. And this result was statistically significant. We also looked at the difference between the baseline and the endline. But when we looked at the difference between the integrated and the non-integrated sites, there was actually no significant difference. But as you can see, the baseline knowledge was really very high, 85%, 86% in both sides. So that would probably explain why there's no big difference between the integrated and the non-integrated sites. Additionally, we also had a very strong community health education program, regardless of integration status. We looked at men, the results for the men who thought that family planning is women's business. And you can see that in the integrated sites, there was a significant drop in the number of, the proportion of men who thought that family planning was women's business. It dropped from 45% to 29%. And ironically, in the non-integrated sites, there was actually an increase in the men who thought that that a relative increase of men who thought that family planning is women's business. In terms of men who thought that family planning use is associated with promiscuity, the primary analysis showed that there was no significant difference between baseline and endline in terms of the men who thought that family planning was associated with promiscuity. However, the analysis showed a possible effect modification, and in doing a sensitivity analysis, we were able to demonstrate a difference in the integrated sites. We were actually able to show a reduction in the number of men who, the proportion of men who thought that family planning was associated with promiscuity. So in conclusion, we can safely say that following family planning service strengthening, familiarity with more effective family planning methods increased overall, but did not differ by integration stages. And I think, as I had alluded to, we had a very strong health education component across all sites, regardless of integration. And then second, that integration was associated with a decrease in negative attitudes among men toward family planning, and possibly this also explains why in the integrated site, as Dr. Dan presented, there was a significant increase in the number of patients accepting family planning. And we also think that further research is needed about how involving men and increasing gender equitability towards family planning influences contraception uptake and use. I think in gender equitability, we're thinking about increasing intercouple communication and the woman being able to make reproductive health decisions aside from the husband. Thank you.
Yeah, thank you. I think it's looking like this panel really rehearsed this thing, because they're really saving time. They're doing less than 10 minutes, and that's great, because as I say, we will use it for the discussion. So please note down your points, and we will get your questions and comments after the panel has completed their presentation. So once again, we have back Professor Daniel Grossman. For those who have just come in, the Vice President of Research at IB's Reproductive Health in Auckland, USA. And he's a professor in the Department of in the University of California, San Francisco. So over to you, Prof.
Yeah, so he's going
he's going to talk to us now. The title of this paper is Patient Satisfaction with Family Planning Services Integrated into HIV Care and Treatment compared to a referral model in Nyanza.
Thank you again. I just want to say I'm making this presentation for Sarah Newman, one of the co-investigators on the study, who was unable to attend the conference. So there's very little research that's been published looking at the acceptabilities or patient satisfaction associated with integrated services. Prior to starting this cluster randomized trial in Nyanza that we presented, we did some baseline research that Dr. Cohen also presented sort of along the timeline, including interviews with men and women. And among women who were not currently using a more effective family planning method, this was again before integration, we found that close to 3/4 of those women said that they would be more likely to use a more effective family planning method if it were available directly in the HIV clinic. So it seemed like there was interest in these kinds of services in the setting, but at the same time there were some concerns that perhaps integration might actually negatively impact acceptability. It might be that integration would increase wait times for clients. It might be that the increased demand on providers could just generally negatively impact patient satisfaction. So these are some of the questions that we wanted to look at. So the data that I'm going to present come from the same survey that Dr. Nova just mentioned. Again, this was a survey that we performed at baseline, so before starting the integration. And then again, after a year of collecting data at all of these sites at the end line, we performed another cross-section survey. She already presented the methods of that survey and the baseline demographics. So the specific questions that I'm going to be presenting the results of here, we're looking at specifically women who reported using a method of family planning. They were asked where they obtained sector maternal child health or family planning clinic, some other public sector site, or a private sector site. They were asked how satisfied they were with the family planning method and how satisfied they were with the place where they most recently obtained their family planning method. And the responses for those questions were on a Likert scale from very satisfied to very dissatisfied. And then they were asked open-ended questions about what were the things that they liked about where they got their family planning method and what were the things that they disliked about the place where they got their family planning method. And those responses were unprompted, and the interviewer would then select the closest response that matched what the participant said, and then would write down those responses. Similar to the analysis that Dr. Gomes just presented, we used generalized estimating equations to estimate proportions and detect differences in satisfaction before and after the intervention while controlling for clustering within sites and baseline measurements. For the positive and negative attributes that were mentioned about the site where family planning was obtained, we did sort of more like a per protocol analysis. So for this, we compared family planning users who received services at the HIV clinics at integrated sites and compared their responses to family planning users at non-integrated sites who obtained their family planning at the MCH family planning clinic or another place other than the HIV clinic. And for this analysis, we also did GEE modeling and adjusted for covariates including age, education, relationship status, health status, and desired fertility play. So, again, similar to familiarity with contraceptive methods, you can see that from baseline, satisfaction with, this is actually satisfaction with the family planning method. This is data only obviously from people who were using the family planning method, which was 82% of women at baseline, 87% at endline. And as you can see, women's satisfaction with the FP method was very high, even at baseline. So 86% of women at non-integrated sites, red line, and 90% of women at integrated sites said they were very satisfied with their method. And that increased to 96% at the endline survey. And these results are the results of the multivariable analysis. And you can see that there was a significant increase in satisfaction over time comparing endline to baseline satisfaction. You can see the covariate for time has a significant odds ratio. However, there was no significant difference in endline between women at integration sites compared to control sites. This table shows where women who are currently using family planning method last obtained their method, if it was a method that required some sort of supply. So women who were using withdrawal are not presented here. And as you can see, most women at integrated sites obtained their family planning method at the HIV clinic, and most women at non-integrated sites obtained their family planning method at the MCH or FP clinic. Although some also obtained their method even at non-integrated sites at the HIV clinic because they were able to obtain condoms there. I should say that among women, satisfaction with the site where family planning was obtained was very high. It was 95% of women said that they were very satisfied, and there was no difference by study arm or between baseline and endline. Also, similarly, among women who had received a family planning referral in the past year, 93 to 94% said they were very satisfied with the services that they received as part of that referral, and there was, again, no difference between the study arms. So for the next analysis about the positive and negative attributes about the site where family planning is obtained, I'm going to be comparing these women, those who were at integrated sites and obtained their family planning at the HIV clinic, compared to these women who were at non-integrated sites and obtained their family planning elsewhere, outside of the HIV clinic. So these are the results of the positive and negative attributes that were spontaneously mentioned by participants. And I'm showing you any attribute that was mentioned by at least 10% of women in the group. And I apologize, the colors aren't showing up so clearly, but the responses from women who were at integrated sites who got family planning in the HIV clinic are the darker blue bars on the left, and women at non-integrated sites who obtained their family planning outside of the HIV clinic are the red-orange bars can see, a significantly higher proportion of women at non-integrated sites who got their family planning elsewhere spontaneously mentioned that the place where they got their family planning was close to home. A significantly higher proportion of women at integrated sites who got their family planning method at the HIV clinic said that they spontaneously mentioned as a good thing about that place was that they were able to get other services at the same place. And also, women at integrated sites who obtained their family planning method at the HIV clinic, a higher proportion of them reported that another thing they liked about the place where they got their family planning method was that the personnel treated them well. I'll just go back to the attribute about the fact that services were low cost and free was a similar proportion in both groups. The only negative attribute that was mentioned by a significant proportion of the sample was that the wait time was too long. And while the proportion was slightly higher for women at integrated sites, that difference was not statistically significant. And then this is the results of a regression analysis. Again, you can see that controlling for other factors, women obtaining family planning at integrated sites had a significantly higher odds of reporting that they liked being able to get other services at the place where they got family planning, and that personnel treated them well. And they were significantly less likely to report that the services were close to home. So, in conclusion, perhaps seeing a theme, but following the family planning service strengthening that we did at all sites, satisfaction with the family planning method, especially the family planning method, improved and did not really differ by integration status. We did find, however, that women obtaining family planning services at the HIV clinic were significantly more likely to report that they liked being able to obtain other services there and that they were treated well by the staff. They were less likely to report that the services were close to home. I'm not sure that this is exactly a negative attribute in this context, since women have to come to the HIV clinic anyway to obtain their HIV care. Instead, I think it sort of reflects the additional convenience of being able to obtain family planning at other sites like shops and mobile clinics for those women who weren't able to obtain it at the HIV clinic. In fact, they become less relevant as HIV care becomes more decentralized everywhere. I think overall, in the context of the improved effectiveness of the integration intervention that I presented earlier, our findings demonstrating the high satisfaction with the integrated model of care support the policies of moving toward integration of family planning services into HIV care treatment.
Yeah, thanks a lot, Dan, because again, keeping time. We go to the last of the 4 papers, and this paper will be presented by Sally Shea, and she's an assistant professor of medicine at the University of California, San Francisco. She's also the biostatistical advisor for the thesis program, which is based in Nyanza province since 2006. So she will take us through the last paper, which is titled Cost Associated with the Integration of Reproductive Health and HIV Services in Nyanza, Kenya. So the floor is yours, Shari.
So, integration is proposed as a cost-effective way to provide services because we think that it will increase family planning